Patient was apparently well 3 months back when she
मैडम से
noticed.
पूछ लो एक बार, मैडम दोनों से पूछ लो एक बार.
Ma'am, should I start, ma'am?
Yeah. Continue.
Okay. My patient was apparently well 3 months back when she noticed postcoital bleeding, which was initially occasional. It was associated with mild spotting, but she later on, the bleeding later on progressed to more frequent episodes of bleeding and also associated with larger amounts of blood. There was no history of any other foul smelling or mucoid discharge per vaginum. There was no history of associated fever, no history of urinary complaints, no history
Your
of
screen is
constipation.
lost.
I'm still sharing the screen.
Yeah, okay now.
Is everybody okay?
Yeah, it's visible.
Okay.
Yeah, continue.
There was no history of any other foul smelling or mucoid discharge per vaginum, no history of any bowel disturbances, no history of any urinary complaints, no history of any other ulcerations, no history of pedal edema or backache, no history of any inguinal swelling, or there was no history of previous pelvic irradiation or any history of cuff, any other history suggestive of distant metastasis like hemoptysis, breathlessness, jaundice, or bony pain. Past history, my patient had no comorbidities. There was no history of cancer or cancer related deaths in the family. Menstrual history, my patient is a postmenopausal female for last 3 years. She had 2 children, both alive and healthy. They are 36 and 32 years old. She had no history of abortions. There is no history of any hormone replacement therapy or OCP use. There is history of tubal ligation, which was done 32 years back. Personal history, my patient is a non-vegetarian by diet. There is no history of intake of tobacco or alcohol, no history of any high-risk sexual behavior, no history of change of bladder or bowel habits. Patient's sleep pattern is normal. Summarizing my case, my patient is a 58-year-old female with history of postcoital bleeding for last 3 months with no history of any high-risk behavior.
So, from your history, what do you think it is?
Ma'am, since my patient is complaining of postmenopausal bleeding, it can and it is not associated with any other kind of discharge per vaginum. My first differential would like to be a malignancy of the cervix.
Okay. You would like to give any other DDs?
Ma'am, there can be other causes like any vaginal pathology or any other cervical pathology like ulcer, which could be secondary to tubercular or a syphilitic ulcer.
CA endometrium, I think.
So, how do you differentiate it between CA endometrium and CA cervix?
Ma'am, carcinoma cervix is often associated with postmenopausal bleeding, but the history of postcoital bleeding is more characteristic of CA cervix.
Anything related to amount of bleed? How is it in endometrium? How is it in cervix?
Ma'am, it is more profuse in endometrium as compared to cervix.
Sure?
Not
It's other way around. Okay?
okay, ma'am.
So in endometrial, there'll be spotting. Okay. In cervical, there'll be because of the growth and all. So there will be more amount of bleed. So most often endometrium patients will come with the history of spotting rather than bleed. Okay.
Okay.
So now you go back to your history.
And why so?
Because there is a ulcerative growth and all in cervix, no? So that will be having neovascularization. so they'll bleed more. In endometrial, it is because of the alteration of the endometrial layer. So it will just present as spotting rather than bleeding from a growth. So that is the reason. And most often, sometimes, like in endometrium, they'll present with the bleeding from the change of a polyp to dysplasia and then CA.
Okay.
So they'll have less amount of bleeding compared to CA cervix, which has proper growth, neovascularization, and then bleeds. So that's how it is.
Thank you, ma'am.
I'm not able to see your screen. Is it problem with my this one or so? Yeah.
Okay. Is it visible now, ma'am?
So, yeah, now it is visible. Okay. So your patient is a 58-year-old.
Yes.
Right? So 58-year-old means postmenopausal.
Yes.
Okay. So can you tell me what is the general presentation age of CA cervix?
Ma'am, it usually presents in 40 to 50 years of age, ma'am.
And the fifth to sixth decade. Okay.
Yes.
So yeah, it can be present in young also, sexually active people. So where there might be HPV infection. So after 20 years span, it will change to malignancy. So it can present like that also. Okay. So anything, so postcoital bleed you told. Yes. What are the other presentations of CA cervix?
Ma'am, it can present. Ma'am, in cases of advanced disease, it can also present as if it involves.
No, let us talk about early first. Early, then advanced.
Ma'am, it can present with not just bleed, it can present with some form of mucoid or mucoid discharge.
Okay, what in other words, what I'm asking is, other than postcoital bleeding, what is the other way of presentation of CA cervix? Not in your case. I'm not asking about postmenopausal. So
Dyspareunia.
Dyspareunia, okay. With terms of bleed, can it present like intermenstrual bleeding?
Simply postmenopausal bleeding also.
No, I'm not asking in your case. That's what I'm telling, that it is not postmenopausal, but it can present
as intermenstrual bleed, ma'am. Yes, ma'am.
Oh, okay. So you should ask about the nature of water bleeding. So it is profuse or it is minimal. What is the amount? Okay. What is the timing? Okay. Intermenstrual or postcoital bleeding or postmenopausal bleeding. So whether it is spotting or bleeding, and whether it is associated with any pain. Okay. And it's associated with any discharge and itching. So whenever you ask about the bleed and discharge, all this should be covered. Okay. So why am I asking about itching? What has it got relation? I mean, what relation it has got?
Ma'am, often the mucoid discharge leads to itching.
Not necessarily. There might be mucoid discharge, but there should be something additional that should lead to. There should be secondary infection post mucoid discharge.
Yes.
Okay, then only it will lead to itching.
Yes.
Okay.
Yes.
Anything. So next you have written no history of fever. So you wanted to rule out any infective cause, right?
Infective cause, yes, ma'am.
So why did you ask about urinary complaints?
Ma'am, often cervical growth can invade bladder and it can cause urinary complaints.
So and cervix said, yeah, tell.
Often, ma'am, if a person has urinary complaints, she might also, if a person has a pathology of the urinary tract, the bleeding might be the source of bleeding might be the urinary instead of the cervical.
I didn't get you.
Ma'am, sometimes the patient might also confuse the bleeding secondary to a urinary pathology.
Achha, you are telling like that. Okay, fine. So suppose cervical growth is there. So if it is involving the urinary tract. Okay.
Yes,
So
ma'am.
first, what will be the, as per staging, what will be the first way by which urinary tract can be involved? Is it direct invasion or it is something else?
Ma'am, it can invade the bladder. It can also invade.
So bladder
Ureter.
invasion comes late, right?
Ureter.
How does it involve ureter?
By invasion of the parametrium, ma'am.
Okay, so in other ways, it can spread through lymphatic spread. No, the lymphatics, lymph nodes might block the ureter, cause hydroureteronephrosis, stage 3B. Okay,
Yes, yes.
so that's how it first involves. Right, later it comes to direct invasion. Right. So okay, then you have asked about constipation and altered bowel habits. So what was in your mind?
Ma'am, any invasion of the rectum.
Yeah.
Or
anything else
And
about which you can
continuous
think?
dribbling of urine also we can ask, na? Urinary complaints is already included. The fistula में continuous dribbling of urine होगा.
Yeah. That any urinary issues can be asked for. Okay. So not only like any dysuria. Okay. So dysuria with increased frequency and
But these are for all
hematuria.
locally advanced, ma'am. For early में
Locally
what?
advanced.
Early में what we have to?
So you need not ask like in specific, don't ask for dribbling of urine and all. So you just tell no history of any suggestive of any urinary disturbances. Then they'll ask you leading question. Okay, if you tell it off, no, then they might not go to that stage. Okay, I mean, see, like she has told. So I was thinking in terms of nodal involvement. So if you tell like no history suggestive of any urinary disturbances, okay, then they will ask you what urinary disturbances you are thinking of, how it will involve, like that. Let them ask question. So you just tell in a broad
Because I'm
perspective.
gyneconco per se, we are thinking ki this is our weak topic.
This
is our weak topic.
It's weak topic for all of us here. We have not touched gynec for in general surgery, so it's okay, no problem. They won't go in that depth and ask you all the recent trials. What are those things? And they will ask basic questions.
For trials, it's okay. For this symptomatology, it's like difficult because for us, every cervix endometrium, post coital bleeding or this bleeding is only the symptom that you were asking. Na, so I was also thinking ki what symptoms we should say.
Yeah, you should ask certain means history wise. You should be ready for the questions. They won't go in depth. I mean, see, you should always cover history which is local, okay, loco-regional, then distant spread.
And gynec, ma'am, you have any book or from where we can understand little bit history taking for cancers of gyneconco?
We have not read anything in specific yet.
Okay.
We were listening to the classes only. I think, we had listened to a little bit of gynec onco webinars. That time we had access and got a link, so we got to listen to that.
Okay.
Other than that, nothing in specific we have read. I have not read. I don't know Disha. Disha?
It has a Barrack book has given something, but cervix case is not that much. Chances are not that much high to get.
They will ask in table viva. Rather than that, little less only.
इसका प्रायोरिटी नहीं है ये केस, मतलब जो प्रायोरिटी लिस्ट वाइज
our third years we don't have any second year in our hospital and not having juniors also. So our third year said Rajiv Gandhi has given CA wall to some patient. राजीव गांधी पीपल आई डोंट नो, CA वॉल्ट दिया किसी को, उसमें क्या बताया कि क्या नहीं पता नहीं.
राजीव गांधी में ना कितना गंदा केस भी दे दो, most of them will pass.
अच्छा,
It's only to test you the approach.
ठीक है.
That's what your approach
Gandhi
to
में
case
maximum pass
matters. Not necessarily you'll know everything in every subspecialty, no? So they'll just see your approach to case. That's it. Okay.
Okay.
So let us proceed. So you have asked about genital ulceration. Why
Yes.
did you ask?
Ma'am, often some pathologies like adenocarcinoma are associated with field cancerization effect, and they're associated with other satellite lesions also, and sometimes the cervical growth might increase and cause a fungation of the a visible fungation of the the vagina or the vulva.
Little later, you can keep it as genital warts or something that you can more. See, don't go into advanced, very advanced and explanations. You can know history of suggestive of noticing any genital lesions. You tell, okay? So later on, if they ask, then you tell ulceration or warty growths or like that.
Okay.
So, are you worried about pedal edema or something else? It's not pedal edema.
The inguinal region edema, ma'am.
No. If the inguinal lymph nodes are blocking,
yes, ma'am.
So where will you get the edema?
Thigh region, lower abdomen.
You will get an entire lower limb swelling, na? So if the inguinal lymph nodes are not draining, so entire lower limb swelling will be there. Okay. So okay, right. Pelvic irradiation by, in terms of treatment perspective, you asked?
Yes.
Okay. Fine. If CA cervix spreads to distant spread, what is the first organ that it would be involving? Distant spread. I'm talking about distant spread.
Liver, in my opinion.
No, you have written, na?
Ma'am, lung and liver, ma'am.
Lung. It is lung. Okay.
Yes.
Apart from nodal spread, it is lung. Okay. So yeah. Then next, this one. So I'm not able to see here. Something is wrong. So what has family history got to do with CA cervix? Is it relevant?
Not really, ma'am. There are no syndromes as such which are known which causes CA cervix. So,
मैम प्यूट्स चेगर में एडिनोमा मैलिग्नम is there, no?
Lynch syndrome and Lynch syndrome, PJ, and they may be associated. Okay, but if they ask, you can tell. Okay. Then so how is menstrual history related to CA cervix?
Ma'am, similar that it might be associated with an intermenstrual bleed if the patient is if she's not premenopausal, then presentation as an intermenstrual bleed, it might present like that.
Okay, and what has parity got to do with the CA cervix?
Ma'am, more in multiparous.
Multiparous, okay. And HRT OCP use. Why?
Ma'am, no significant association. Just for the
so at this level, you can tell I am not still sure whether it is CA cervix or endometrium. Okay, because there was spotting. I would like to rule out the causes of endometrium as well. So you can tell that way. Okay. So and tubal ligation. Okay, fine. Next. Okay. What is relation of smoking to CA cervix?
Ma'am, it is the tobacco is related to CA cervix.
How?
There is an increased incidence of CA cervix in patients who are who consume tobacco.
That is true. Why?
Ma'am, in general, tobacco is a carcinogen. Also, or the precancerous lesions, there is a the chances of precancerous lesions into developing into cancerous lesions is increased in patients who are consuming tobacco.
So there might be some immunosuppression leading to the sexually transmitted diseases, HPV infection, okay, which might flare up the transformation from pre-CI carcinoma in situ to CS cervix early, okay, in immunosuppressed people. Okay, and next. Okay, fine. Now, anything you missed? Anyone can tell. Anything she has missed something.
Iris sexual behavior she has told.
She has
You
told.
should ask about vaccination.
Another one, vaccination is important. She missed one more also. Did you ask about the partner?
STD in the partner.
So you should ask in usage of any protective measures or history of any STDs in partner, okay, and any history of IV drug abuse, okay. These things are. Other than this, I think most of the history is covered. Okay, socioeconomic status. How is it related to CS cervix?
Mostly associated with patients with lower socioeconomic status.
Why?
Ma'am, because of the
poor hygiene.
Poor hygiene.
Yeah, it's the same like what we discussed in financial.
Yes.
So, yeah.
One new question,
Proceed.
ma'am, I got to know in this. How you will assess how you will say the patient is have a low socioeconomic status?
What is that BJ Prasad classification?
Kuppuswamy
Kuppuswamy is there, BJ Prasad is there. So these two are per assessing based on they have some 3,500. Actually, it's very less, but 3,500, less than 3,500, they have divided into 3. So based on that, less than 3,500, 3,500 to 6,000, and more than 6,000 income.
उसमें income, education and one more parameter. What is our profession? वो 3 occupation, वो 3 पैरामीटर्स को ज्वाइन करके उन्होंने एक स्कोर बनाया है. मैक्सिमम स्कोर 30 रहता है and less than 10 score is the lower socioeconomic status. Kuppuswamy, this is Kuppuswamy.
So next you proceed.
Okay. I examined my patient in a well-lit room with adequate exposure with informed consent in the presence of a female chaperone. My patient was conscious, oriented to time, place, and person. She had normal build and was well nourished. She had a BMI of 27 kg per meter square with a ECOG performance status of 0. Her BP was 132 by 86 millimeters of mercury taken in the right arm supine position. Pulse was 88 beats per minute. She had no pallor, icterus, clubbing, cyanosis, or lymphadenopathy or dependent edema. I did per abdomen examination. Her abdomen, it was soft, non-tender with no palpable mass. Umbilicus was central. All quadrants were moving equally and no ascites could be elicited. On pervaginal examination, inspection, the vulva was normal. Urethral orifice, clitoris, and labia appeared to be normal. Vaginal walls appeared to be normal. On palpation, the cervical lips had 3 into 3 centimeter mass, which was palpable on the cervical lip. The fornices were free. Uterus was anteverted. There was no adnexal mass, which was palpable. I further did a perspeculum examination in which there was no lesion which could be seen on the vaginal wall. The fornices were free. On examination of the cervical lips, a 3 into 3 centimeter ulceroproliferative lesion was seen in the posterior lip, more towards the right side, bleeding on touch. And the perrectal examination showed a normal mucosa with free parametrium. These are the photographs. This is the MRI of. Should I stop here, ma'am?
Yeah. So, how? So, in general examination, what are you going to look for in a CS cervix?
Ma'am, for general examination, my patient, since she's been bleeding, she can have pallor. She might have dependent edema, which will be suspicious of any venous or lymphatic obstruction, or
yeah, so any generalized lymphadenopathy, all this is what you look for. Okay, so now we'll in abdominal examination, anything specific you want to look for in a case of CA cervix, taking it to be CA cervix?
Ma'am, inguinal lymph nodes, I want to palpate for inguinal lymph nodes, any abdominal, any abdominal mass, if I could palpate. Pelvic mass.
Oh, okay, fine. And then per vaginal examination, how do you do PV and PR, PS and PR?
Ma'am, for per vaginal examination, I will first explain the patient the entire process, and I will explain her that I will be inspecting and then palpating and then doing a per speculum examination with a per rectal examination. I will be exposing her adequately from the umbilicus to the mid thigh. I will be asking her to lie in lithotomy position and in the presence of a female chaperone. With adequate information provided, I will first inspect, and then while palpation, I will like to use a lubricating jelly for doing a per vaginal examination. While doing a per vaginal examination, I'll use the index and the middle finger for doing a per vaginal examination. While doing a bidigital examination, I will use one finger for the per vaginal and one finger for the per rectal examination for examining the parametria.
Yeah. What are you going to see in per vaginal examination and what are you going to see in per speculum examination?
Ma'am, in per vaginal examination, first of all, I will see the if the uterus is anteverted or retroverted, and if I can, if the fornices
see the uterus.
No, ma'am. In per vaginal examination from outside to the inside, I will look at the labia, if there is any lesion, if there is any warts or lesion on the labia, and the urethral orifice, the inspection of the urethral orifice, the labia. Then on further palpation, I would like to palpate the labia as well as the vaginal wall if for any kind of edema or thickness. Then on further per vaginal examination, I will look for the vaginal walls, the anterior and the posterior vaginal wall, bilateral fornices, the lips of the cervix, if the uterus is anteverted or retroverted, if there is any fullness palpated in the fornices, if there is any kind of adnexal mass, if there is any uterine mass, these all can be seen in the felt or in the per vaginal examination. In the per speculum examination, ma'am, I'll be able to assess the vaginal walls as well as the cervical growth better. I'll be able to assess the fornices better. While doing the per rectal examination, I'll be able to look for any kind of rectal extension, as well as for the parametrium, I'll be able to assess better on a per rectal examination.
So how do you examine for the para?
Ma'am, for the parametrium, we'll do a bidigital examination with the index finger for the vaginal examination and the middle finger for the rectal examination. And we tell the patient while using a lubricated jelly, we'll be able to do the bidigital examination, and I'll try to feel for the if there is any uh, if there is any kind of fullness or growth or nodularity in the bilateral parametria.
So is there any, how much para is involved for that? How do you look for? So that it has got relevance, no? Suppose there is doubtful para involvement.
Yes.
How, like, if para is involved, till where it is involved? I mean, the extreme is lateral pelvic wall.
Yes.
Okay. So how do you assess that?
Ma'am, if we'll be able to check for the if both our fingers are meeting and we are able to assess the rectovaginal septum completely from one side to the other, and there is
So you will see, suppose it is indurated,
yes,
or it is thickened. Okay. If it is thickened, it is doubtful. Okay. So if it is indurated, how far from the midway? Okay. On one side, when you sweep the fingers, okay, how far? Gynae onco people, they'll tell in terms of centimeters. Okay. So whether it is, we will tell, like generally we are like in midway or crossing the midline on one side. So where is the induration extending up to, or where is the involvement, infiltration extending up to? Whether your fingers are able to like be in a parallel way, that you are able to feel your index finger and middle finger, or is there any distance? In case of infiltration, you will not be able to do so, no? So
yes, ma'am.
Is there any involvement? You have to tell up to the midline, midway, or 2 centimeters away from the midline, or crossing the midline till the pelvic wall. So that is how you'll tell.
So, ma'am, we are comparing with normal side, na? Or is any मतलब bilateral parametria we are assessing. तो normal हमारा
bilateral will assess.
उसमें
Sometimes bilateral para are involved, right?
then how will
So then no, your assessment is based on your feel between the index and middle finger. Okay. If it is soft, supple, and you are able to correctly approximate your index and middle finger when you are sweeping through, then it is not involved. Okay. If you are feeling some thickening, then it is doubtful involvement. If it is, you are not able to approximate, you are not able to sweep through parallelly both the fingers, then it is infiltrated. Okay. So it's all like relative. Some will feel, some will not feel. Confirmation is through MRI. Okay. So, but clinically, if it is involved, you should be able to feel. Right?
Ma'am, when you say lateral, as in up to the lateral pelvic wall, how is the midline coming there? I mean, I didn't understand exactly what you meant by that.
We are starting from middle, na? We are starting from middle and going to lateral.
From the middle, no, ma?
Okay, so okay, got it.
From vagina and rectum. So you're going from midway to the other end. Again from midway to the other end. So that's how it is. Okay.
And ma'am, so also another big doubt I had is, do we do a speculum first or do we do a PV first?
Generally, it is like inspection followed by palpation.
Speculum ही करते हैं ना routine में.
But generally in outpatient department, you will not get speculum. By the time you will get speculum, we'll do a PV.
PV, yeah. But we are supposed to say it in the other way.
Inspection followed by palpation. Okay. So yeah. So now you have finished your this one parametrium free and this one. So what do you think it is at the end of history?
Ma'am, my patient, summarizing, my patient.
Pulse speculum, we can comment on parametria.
No, per rectal.
No, pulse speculum, you'll never comment on parametrium. You will only comment on cervix.
What we are
She
able
has
to
written,
see,
no?
na?
No, I've written per-rectal examination and then parametrium.
Okay.
In per-rectal only you will be able to comment on parametry. She has written correctly only.
नहीं मैम, वो जस्ट मैं पूछ रही थी कि क्या क्या बोल सकते हैं हम लोग पर स्पेक्युलम में.
Per speculum is for inspection. Okay, generally you tell it before PV. Okay.
Okay.
So how is cervix to look? Is it bleeding? Okay. Where is the growth located? Ulceroproliferative or ulceroinfiltrative? That kind. Okay.
Okay.
Yeah.
My patient, 58-year-old postmenopausal female, who presented with complaints of postcoital bleed for last 3 months. With on examination, she had a 3 into 3 centimeter growth on the posterior lip of cervix, and with the free parametrium and
No, you define and tell in 2 sentences. Practice telling summary. Okay. Sometimes you will not be able to present the case. They'll ask only to summarize.
Okay.
So take 1 minute and tell. Okay.
Yes, ma'am. Summarizing my case, my patient is a 58-year-old postmenopausal female who presented with history of postcoital bleed for last 3 months, has no high risk behavior. On examination, she had a 3 cross 3 centimeter ulceroproliferative growth on the posterior lip of cervix with no palpable inguinal nodes or no involvement of parametria.
Okay. You can put it as 1 sentence. Okay. 58-year-old postmenopausal lady with a history of postcoital bleeding of 3 months duration with no history suggestive of high risk behavior. On examination, showing 3 cross 3 centimeter ulceroproliferative lesion involving the posterior lip with no obvious parametrial involvement or lymphadenopathy or any signs of distant metastasis. So in 1 sentence you tell. Okay.
Okay.
So
when you
Disha?
asked for summarize, na, you should tell which points are important in for staging.
Staging, yes.
हाँ, वो चीजें तुम्हारे समरी में जितना पॉसिबल हो उतना आना चाहिए.
ठीक है.
And always try to tell it in 1 maximum 2 sentences. Okay. You can't keep it in paragraphs. Okay.
Okay.
So only positive findings which matter to your staging, as Disha told. Okay.
Okay, ma'am.
Right. Disha, you'll ask.
How you like to proceed?
Ma'am, first of all, I will like to take a cytology of the lesion, ma'am, and
Why
I
cytology?
think
There is an
जब
obvious
mass
growth, na? Why do you want to take cytology?
एक्चुअली है ना, सीए सर्विक्स इज लाइक अ स्पॉट डायग्नोसिस टाइप ऑफ केस, तो उसको तुम डायरेक्ट बायोप्सी बता सकते हो.
ठीक है मैम. I will like to take a punch biopsy of the lesion.
See, as I told you last time, please divide your management, okay? To confirm
I will
diagnosis.
like to confirm my diagnosis, stage the disease, and then manage the patient, ma'am.
Yeah. So to confirm your diagnosis, that will be easy also.
Yes,
And
ma'am.
people won't tell you're telling an invasive thing first like that. When you tell confirmation, it is confirmation. That's it. Okay.
Okay, ma'am.
So
I like
you
to
divide.
I like to confirm my diagnosis of CA cervix by taking a punch biopsy of the lesion, ma'am.
How do you take
How will you
biopsy?
take biopsy?
Ma'am, I can take the biopsy on an outpatient setting or an inpatient setting. I would like to take the biopsy from the most representative part, not involving the necrotic region.
What is the position? What is Any anesthesia you want to give, or
ma'am, ma'am, the biopsy can be taken on an outpatient basis. In some cases, it might also be needed to take an examination under. We also might need examination under anesthesia. It is taken in a lithotomy position, and it is done under under a perspeculum guidance, and with informed consent, and with the help of a punch biopsy forceps.
And what all you have to keep in your tray?
I have to keep a Cusco speculum, along with that of formalin, a jar of formalin with punch biopsy forceps.
And a
Pack.
pack.
Pack. Gauze नहीं चाहिए pack करने के लिए?
Yes, ma'am. We'll also require gauze piece, and if need be, some adrenaline to pack, vaginal pack, just in case if the patient bleeds after the biopsy.
And you will observe the patient post biopsy, right?
Yes, ma'am. We'll not ask her to immediately get up. We'll ask her to stay there for a while, and when she's feeling okay, then we'll ask her to we'll observe her for a while.
So, do you need anesthesia?
Ma'am,
not examination under anesthesia. I'm just asking.
Ma'am, usually not required, ma'am.
Just
Lox jelly we are using now.
Lox jelly you have to use. Okay.
Yes, ma'am.
So if it is not visible, in your case, there is a visible growth. Suppose
yes,
it's not visible. So what are the options you have got to do?
Ma'am, we can use a colposcopy, and VIA we can use, and we can use, with the help of the colposcope, we can use various dyes, like we can use with the help of the
हम लोग पता है क्या करते हैं, when we are not able to see ना, तो पिपलीस डिवाइस से एंडोमेट्रियम का एस्पिरेट लेते हैं.
So there is something called ectocervix and endocervical. Okay. Yes. So what you are telling is ectocervix. So either you do a smear, do cytology, or you do a VIA, or you do Willi, or colposcopy. These are all when you can see something. I mean, when something is like dysplastic and you are able to see. Suppose it is endocervical growth or a barrel cervix which has a growth. So how do you assess that?
Ma'am, by doing a hysteroscope. Hysteroscope, ma'am.
नहीं बे, अभी बोला ना, इसने बोला ना.
Please.
Pipple biopsy. Okay.
Yes.
So sometimes while doing a pipple biopsy, patient might have vasovagal attack. Okay, you don't take it for granted. You have to do it under controlled conditions. Okay. So then okay. So now you have
हम लोग
told
सेकेंड सेटिंग में ये करते हैं, मतलब जब ये सब जो हमने किया पैप स्मीयर एंड ऑल, इफ इट इज नेगेटिव, then in second setting we do this VIA and all. So
yeah, if it is in the endocervical region, okay, just reaching means okay. One more question. So where does this CA cervix occur? What is the zone?
Junctional zone.
Transformation zone.
Transformation zone. So what is the epithelium there? Change of epithelium.
Squamocolumnar junction.
And so how does this transformation zone vary with the age?
Ma'am, it involutes with age.
No, in puberty. Suppose it is in puberty, it is in menopause. So how it changes? Whether it moves down, moves up?
Ma'am, it moves upwards towards.
In menopause or puberty? So in menopause it moves up.
Yes.
Okay.
Yes.
The young people post puberty, it moves down. That's why most of the infections or HPV ascending infections, that time it is more common, okay, because this transformation zone lies more down. Okay, so yeah, so that is for your confirmation. So can you tell me something about pap smear? What is pap smear? How do you do it?
Yes, ma'am. We can do screening pap smears. We start at the age of 25, and pap smears are usually taken with the help of a we usually take a IR spatula, and with the help of that spatula, the patient is again positioned in a lithotomy position, and the speculum is again, we visualize the cervix with the help of a speculum. After proper exposure, we will take with the help of a IR spatula, we take the representative samples from both the ectocervix and the endocervix. And
so how do you do it? It has got some 3 parts, no? Pap smear kit has got 3 things.
Yes.
One is spatula, one is
the liquid. There is an endocervical brush, there is a spatula, and there is the carrier liquid.
Okay. So the cyto brush you have to rotate for 360 degrees.
Yes.
Okay. All throughout, and then so what are the prerequisites you will tell patient before taking a pap smear? What are prerequisites?
We tell her for abstinence for 2 weeks. We tell her
3 days.
2 days. Okay, 48 hours.
Okay.
Not to use vaginal tampons or not to use any vaginal pessaries. Okay.
And patient should not be menstruating.
Patient should not be menstruating.
So this pap smear you will collect. There is a liquid-based cytology also, no?
Yes.
So in liquid-based cytology, the artifacts are less. So compared to conventional method. Okay. So
उसमें हम लोग मैम तुरंत स्लाइड बनाते हैं, उन स्लाइड में हम लोग स्प्रे करते हैं. That spray also they can
that
ask.
is fixative. What is the used fixative for pap smear?
Some alcohol is there.
How much alcohol?
95%.
Correct, 95%. So apart from this, for detecting HPV, anything else you have?
HPV DNA we can use, ma'am.
Nucleic acid amplification test, DNA testing.
Yes.
Okay. And so this is, so what are the results on pap smear? And what is the staging that is followed for? There were many terminologies, but what is most commonly followed?
Ma'am, we use the Bethesda system for giving the report pap smear. It has various components, like if the cytology specimen is adequate or not, if there is any pathological cell visible or not, there is any other infection which is seen or not, and if there is any atypical cells which are seen, it is either given in the form of ascus, LSIL, HSIL, or or CIN 1, 2, and 3.
What's ascus?
ATP of
unknown significance.
Atypical cells.
Atypical squamous cells of unknown significance.
Yes.
Okay. So there was there are 3 things. Bethesda can be used. There was something called HCIL, LCIL, all these terminologies were used. CN 1, 2, 3. So generally now CN 1, 2, 3. Now it is whatever says mild, moderate, severe dysplasia. That is reagent terminology. REAGE. Okay. So yeah. Then so that's about your biopsy and detection. Next, what do you want to do?
Ma'am, for staging the disease, if I have a confirmed biopsy specimen that says carcinoma cervix, I will like to stage. For local staging, I would like to do a MRI with and without contrast. of the pelvis.
You want to do with contrast or without contrast?
With contrast.
Why with contrast? Why without contrast?
With contrast, I will be able to see the lesion along the bladder. I'll be able to see more the relation of the lesion with the bladder. I'll be able to see more. I'll be able to appreciate better.
Okay. Anything else? But it's MRI is for loco-regional?
Loco-regional assessment, ma'am.
Yeah, loco-regional assessment. So for nodal assessment, what is more sensitive?
With contrast, ma'am. Ma'am, MRI with contrast, ma'am.
See, if they are having some urinary issues, creatinine is raised, then not necessarily you can use contrast. Okay. So for nodal, especially nodal staging, CT or PET CT are more sensitive than this. Okay. Yes. So CT has some specificity of sensitivity of 50%, and I think PET CT has 80%. So for loco-regional spread, means through the layers and all, what you can see is through MRI, more specific. So, okay. And what else you want to see on MRI? Tell me what all you will see.
Ma'am, I can we can also assess the stromal invasion on MRI. We can assess for the region of the parametrium, the nodes, invasion of if there is any rectal involvement, bladder involvement, if the ureters are not, if there is any sort of hydronephrosis, or if the cervical lesion is involving the vagina, the size of the lesion.
Spread you told.
Yes, ma'am. The size of the lesion.
Any ascites or any distant metastasis?
Yes, ma'am. Yes, ma'am.
Okay. So you can see the nodes also. Okay.
Yes.
And okay. So now you have done MRI. You have pictures, right?
Yes, ma'am. One doubt I had, ma'am, will we do, if I have a 1B1 lesion, will I do a PET CT even in 1B1?
How do you know it is 1B1?
Ma'am, if it is less than 2 centimeters.
The PET CT, basically PET CT is not the diagnostic investigation because of the bladder interference. Okay.
Yes, ma'am.
In
yes.
PA cervix especially. So
yes.
whatever you stage is through MRI pelvis. Okay. At the most, if you have doubt, MRI abdomen and pelvis.
Yes.
Okay. Not necessarily every time contrast needs to be given. Okay. You can see as well without contrast also. Okay.
Okay.
And because most often, sometimes cases have increased serum creatinine, obstructive uropathy. That time you cannot give contrast. So you can do it in plain also. Okay. So, and yeah, PET is not the diagnostic investigation unless you have suspicion of distant metastasis. Okay.
Ma'am, let's say if we're saying that for nodal involvement we prefer PET CT, so do we do PET CT regularly?
Not in every case, ma. No. PET CT is only in locally advanced when you are suspecting some there is some hydroureteronephrosis. Okay, increased nodal burden that is visualized. Suppose pelvic nodes are there, so you are having suspicion of any distant other metastasis also. Intra-abdominal or supraclavicular, then you will go for PET CT. Otherwise, not needed. Okay. MRI as well can detect. Okay. It is not that MRI will not detect nodes, but if they ask you what is the PET CT prefer, why is in PET CT, when is it preferred over MRI? If it is locally advanced or metastatic disease, you can see the nodal burden better. The pickup is better. But for CA cervix, the diagnostic investigation of choice for staging is MRI. Okay.
Okay.
There's no doubt. Pet you should not tell.
Okay.
Okay.
Ma'am, these are the images. This is a CE axial.
You have a cursor with you?
I can try, ma'am. Yes, ma'am. I might not be able to.
Yeah, no issue.
Okay. Ma'am, this is a contrast enhanced MR film axial section of pelvis of the patient. This MR shows from the inside to the outside, ma'am. The MR section shows cervical growth, uh, which is approximately 3 into 3 centimeter, which is mostly on which is T2 hyper intense, mostly on the right side of uh, and which has distinct fat planes with no involvement of the bladder or the rectum. The bilateral parametrium appears to be free. There appears to be no enlarged nodes, and
how about uterus?
Ma'am, in the next section, ma'am, in this section, I am not able to appreciate uterus. I'll require the next section.
Okay.
Can I go
Ma'am,
to the
this
next?
is anterior lip or posterior
Can see
lip?
actually. What?
If the lesion is towards bladder, then it will be anterior, na?
Actually, this section it's not very clear.
Because
I'm not having
on
cursor
examination she was saying कि posterior lip में है. तो
नहीं एक्चुअली पोस्टीरियर लिप राइट जंक्शन एंड एंटीरियर लिप भी है, मगर एमआरआई में तो लेफ्ट साइड दिखा रहा हेटेरोजेनेसिटी
and loss of flat planes में दिख रहा है.
12 o'clock to 3 o'clock.
No, you cannot tell loss of fat plane in one image.
Indistinct something. वो जो black line रहती है between the bladder and वो.
Yeah. Here it is. You have to see consecutive images. It's not only in one image that you should tell about fat planes.
Ma'am, in the pictorial image, it was from 6 o'clock to 11 o'clock, involving the posterior lip, anterior lip, and the junction on the right side. But in MRI, it is heterogeneity is on the left, na? More or less.
Can you show another image?
Avneet,
Yes,
can you see
ma'am.
the
Have
image?
any
Show that
axial
image.
I'm
Image.
yeah.
Show that perspective. See the image. It is involving the anterior lip, junction, posterior lip. But on the MRI, it is showing more towards the anterior lip and onto the right, left of the patient.
You have any other axial image?
Yes, ma'am, I do. Ma'am, actually, this patient also had a fibroid. I think there might be some sort of interference with that. It could be.
Is that fibroid important for your case?
Ma'am, it was one of the findings which I should have palpated for in the pervaginal examination, but I could not appreciate on my pervaginal examination.
And not necessarily like you'll be able to feel it unless it's a huge fibroid.
Not for examination purpose, but I am asking about is the
she's asking about
fibroid change your treatment of management? Plan of management?
No.
Anyone else?
It don't
Ma'am,
change.
if we are considering
Postmenopausal
fertility
patient with fibroid, ma'am, it's a risk
59
factor.
years. How?
So basically that IVRT, location of that fibroid is important, and IVRT sometimes it will interfere with the placement of that tendon, and that's why sometimes surgical option is better to choose when there is a fibroid is there.
Okay.
And
But
anything
if
else you will see?
parametrium is involved, then what we will do? Then so we have to go for definitive CTRT only, no?
That is first we give EBRT, na?
Yeah, first we will give EVRT, then we'll go for brachy.
It will, if it is location is inside like lower location है तो problem है.
ओके तो मैम उस कंडीशन में क्या करना है, मतलब हमको ये मैं पूछ रही हूँ। अगर वो पूछते
General
हैं कि
surgical
पेशेंट
approach
का
better रहता है
स्टेज जो
उसमें.
है स्टेज इज नॉट ऑफ सर्जरी एंड
बट सर्जिकल ऑप्शन इसमें चूज कर सकते हैं और फिर पोस्ट ऑपरेटिव CTRT दे सकते हैं.
ओके ठीक है.
Anything else, Avneet, that in uterus that you should be considering, which will alter your plan of management? Any hematometra, pyometra?
Yes, ma'am. There was ma'am, patient can present with pain abdomen if she has hematometra or pyometra. In this section, we can see some hyperintense lesions in the uterus, uterine fundus, which might be hematometra or pyometra.
So sometimes you have to sound the os for radiation and all. So if os is closed, okay, and there is hematometra or pyometra, okay, then you have to drain it before, okay, before starting the treatment.
I have seen, I went to brachy, ma'am, they are sounding all patients.
That's what. Sometimes it is not possible to sound when the os is closed. Okay. So that time they have to do dilatation, drain, and then start the treatment. Okay, that is how it matters in management. Okay. So next, what do you want to do? So what stage do you think is your case in?
Ma'am, my patient is a 1B2, stage 1B2 CA cervix, and after I've confirmed the diagnosis and staged my patient and ruled out distant metastasis, I will like to give her the option, since she's a 1B2, I will like to give her both the options.
अच्छा, मैं पूछती हूँ, okay? So there are now you tell me, you have biopsy, right?
Yes, ma'am.
So what are the things in biopsy you want to see, biopsy report?
Ma'am, first of all, the pathology, if it is a squamous, adeno, or a neuroendocrine, if it is a squamous, what grade it is, if it has any LVI, or what depth of invasion it has.
Okay. So what are the types of squamous cell carcinomas?
Ma'am, it can be squamous, adenosquamous, or
no, there are types of squamous, no?
Keratinizing, non-keratinizing, no?
Keratinizing, non-keratinizing. Large cell keratinizing, non-keratinizing, small cell, verrucous, okay, all these things. So most common is which type?
Keratinize.
Okay, squamous cell and keratinizing. And So how is it different from oral cavity? This keratinizing and that keratinizing?
Ma'am, this is also P16. This is P16 positive.
No, you tell me. Any one of you can tell me next time. Okay. How is it different from cervix and oral cavity? This,
Oral cavity will be
squamous cell keratin.
non-keratinizing, na ma'am?
No. If it is keratinizing, how is it different? Okay.
Okay.
And what are types of adeno?
Ma'am, adeno is divided by a new criteria. It's called the Selby's criteria. Based on that, it is graded grade 1, 2 and 3.
No, adeno CA का types क्या है? It is clear cell, endometrioid, adenocystic,
serous, yes, ma'am.
adenoma malignum, or it can be mixed, as you told, adenosquamous.
Yes.
Okay, or neuroendocrine. Any other tumors you know other than squamous, adeno, and mixed?
Ma'am, neuroendocrine, it has a bad prognosis.
No, other types I'm asking. Can it be melanoma? Can it be lymphoma? Can it be sarcoma? So that things. Okay. Other than that, what else you want to see on? Yeah, you were telling something about Sedley's criteria. Tell.
Ma'am, Sedley's criteria, we see the size as well as the depth of the lesion. If it is a superficial lesion and a superficial lesion more than 5, ma'am, Sedley's criteria is a criteria which is used to determine if the patient needs a post-operative radiation or not. If it is a superficial lesion, any lesion more than 5.
What are the 3 components of Sedley's criteria?
Lymphovascular invasion, size and depth, ma'am.
Lymphovascular invasion, stromal invasion, stromal invasion and size.
Yes, ma'am.
Okay, so what is it? Can you tell?
Ma'am, if the lymphovascular invasion is ma'am, if the lymphovascular invasion is present and if it is a superficial lesion, the lesion needs to be more than 5 centimeter. If the lesion is a deep or middle 1/3, if it is involving middle or deep 1/3 of stromal invasion, and if it has positive lymphovascular, if it does not have lymphovascular invasion, the lesion needs to be more than 4 centimeters. If the lesion is involving the deep stroma, and if it has lymphovascular invasion, any size of the lesion will need radiation.
Any 2 criteria of these 3?
Yeah. See, easy way to remember, I'll tell you, okay? If it is in the superficial most part, means one is less, okay? The other should be more. So that other 2 criteria, that is lymphovascular space invasion should be there, and it should be more than 5 centimeters.
Yes.
So other 2 should be more. If it is in the middle, okay? So it should be less than more than 5 centimeters. So ho gaya. Abhi next is more than 2 centimeters with lymphovascular invasion. If lymphovascular invasion is absent, then it should be more than 4 centimeters.
Yes.
Okay. If it is deep, any tumor size will do, but it should have lymphovascular invasion. Okay.
Yes.
So that's how you can easily remember. So okay. And can you tell me what is Peters criteria?
Ma'am, this is for the requirement of adjuvant chemoradiation in patients of CA cervix. And it states if there is any positive margin, lymph node or parametrium, the patient will require adjuvant chemoradiation.
Any of 3 P's. Okay?
Yes, node, margin and parametrium.
Yes. Okay. So you have come to that. We have discussed investigations. We have discussed biopsy, and shall we proceed to surgery? Disha, anything else there?
newer concept है कोई न्यू एडजुवेंट अप्रोच
Ma'am, there is in cases which are not operable, there is there is a new trial which says that neoadjuvant chemoradiation followed by neoadjuvant chemotherapy followed by chemoradiation is associated with better prognosis as compared to only chemoradiation.
Yeah, the trial you read and
Yes,
it
ma'am.
may ask your trials. Second thing is in investigation, you can be asked about when will you do colonoscopy, when will you do that.
When will you do cystoscopy? When will you do?
Cystoscopy का पूछ सकता है.
Yeah, when will you do cystoscopy?
Ma'am, whenever there is any whenever there is a suspicion of any bladder invasion, mucosal invasion of
Or indistinct fat plane we are seeing in the radiology, then to confirm it or to rule
Either
out.
clinically or radiologically if you have suspicion.
Yes.
So that
Clinically,
and
hematuria.
suppose there is bullous edema.
Then it doesn't change the stage, ma'am. Unless the mucosa is not involved, it will not
Change the stage.
Yes.
When will you do colonoscopy?
Ma'am, whenever there is a suspicion of the rectal invasion by clinical or radiological.
अभी आते हैं staging. Can you tell me staging?
Yes, ma'am. Stage 1 is when it is confined to the cervix. It is divided into 1A and 1B. 1A is microscopic disease that is less than 5 mm. And it is further divided into less than 1A1, which is less than 3 mm. 1A2 is less than 5 mm. 1B is macroscopic disease. 1B1 is more than 5 mm but less than 2 centimeters. 1B2 is more than 2 centimeters but less than 4 centimeters. 1B3 is more than 4 centimeters. Stage 2 is when the tumor involves the when the tumor is involving the lower when the lesion is involving the upper 2/3 of vagina or the parametrium. So when it is involving the upper 2/3 of vagina, it is 2A1. When it is involving the parametrium, it is 2B. And whenever it is involved, stage 3 is when it is either involving the pelvic side walls or if it is involving the pelvic lymph nodes or the para-aortic lymph nodes. If it is involving the pelvic side walls, it is 3A. If it is involving the pelvic lymph nodes, 3B. If it is involving the para-aortic, it is 3C. Stage 4 is if it is involving the pelvic.
You told 3A is what?
3A is, ma'am, pelvic side walls.
No.
Lower third of
it involves lower third of vagina with no extension to pelvic wall. Okay.
Yes, ma'am. Sorry.
B1 is parametrium, 3 is B1, B2 again.
B is what?
Parametrium.
Parametrium involvement.
2B is parametrium. 3B is hydronephrosis.
3A is lower 1/3 of vagina. 3B is parametrium. 3B is pelvic side walls. 3C is lymph nodes, which is divided into C1 and C2. C1 is pelvic lymph nodes. C2 is para-aortic for retroperitoneal lymph nodes. And stage 4 is divided into A and B. If it is involving the pelvic structures, then it is 4A. If it is just involving the distant organs, it is 4B.
What is the change of this? Which year it was? Whatever you are telling?
Ma'am, it was changed in 2019, I think.
18. Okay.
Yes, ma'am.
So, what was the prior staging? What were changes?
Ma'am, the depth of invasion. The earlier staging involved the depth of invasion, and it emphasized on the surgical staging. Now we take in account the radiological staging, as well as the size of the lesion, the size and the diameter of the lesion are a part of staging now.
Yeah, there was this concept of stromal invasion and depth and extension, that less than 7 mm, that all things were removed.
Yes.
And now lymph nodes are included. Okay. And one B3 is new one. Okay.
Yes. Yes.
And previously they told clinically visible lesion in 2A1 and A2. That was not there. Now it is not. It is like less than 4 centimeters, more than 4 centimeters. Okay.
Yeah.
And yeah. So next is told about the staging. So what is early CA cervix and what is locally advanced? What stages are early?
Ma'am, from 2B onwards, from 2B to 4A is locally advanced CA cervix, and 1A, 1 to 2A, 1 is early CA cervix.
Okay. So now we'll discuss about fertility sparing. First you tell me what are options of treatment that you will take early CA cervix. Okay.
Yes,
your patient is having early CA cervix.
Okay.
See squamous cell carcinoma.
Okay. Okay.
So now she's one patient is not, she's 20 years old. Okay.
Okay.
So 21 you'll take. Okay. We can do this one, no? And so, and other patient not completed family, other patient completed family. Okay.
Okay, ma'am. Yes,
she
ma'am.
is 25 years old. And other patient, she's not fit. Okay. So elderly lady not fit. So what are the options of treatment you give in these three people?
Okay, ma'am. Ma'am, first of all, what form of biopsy did I take? If I start from stage 1A1, if my patient is a 20-year-old female, and if I have taken a cone biopsy, and if my conservation criteria are met, and all of the conservation criteria would mean if the margins of my cone biopsy are negative.
So I will tell you, one is one cone biopsy you took, this one had no LVSI, one had LVSI. So how do you proceed?
Ma'am, the patient who did not have a LVSI, if her depth of invasion was negative, margin was more than 1 mm, and if she was squamous, and then I will